So, bone and joint infections can at times be very mysterious, and this is one case which required four orthopedic surgeons and close collaboration with the radiologist, microbiologist, as well as infectious diseases for arriving at the diagnosis. I'm Dr. Neha Gupta, infectious diseases specialist from Gurugram. I'm attached with Fortis Memorial Research Institute and founder of NG Swastha, which is our infectious diseases clinic. So I'm going to basically touch upon the challenges in the diagnosis, the treatment plan, as well as the surgery. So this is a case of a mysterious bone infection in a 59-year-old gentleman from Rewa, Madhya Pradesh, who had no comorbidities. And in November, he started having fever, which was low grade. And a week later, he did telemedicine consultation with us. And on inquiry, we found that this patient had a normal WBC count, but the neutrophilic predominance was seen here. And there was a mild increase in the ESR as well as the CRP. This was definitely up. He was also complaining that there is right forearm pain, headache, neck ache, and for which he was on painkillers. So at this time, we thought that the possible etiology could be this probable salmonella infections. The cultures were advised for this. However, it could not be done in Rewa in Madhya Pradesh. So empirically, we started this patient on cefixime in the doses which we treat for salmonella infection. So the fever subsided, but the forearm pain persisted. So because of this, he traveled from to us in Gurugram, and as there was significant forearm pain, an MRI was performed, which revealed that there was this hyperintensity at the metaphysis in the right radius. Along with that, there was intense edema. Now, with this, we reached out to the orthopedician, who on examination said that there is no infection and perhaps we should continue with the painkillers. But since there was there was joint effusion, we sent off the blood cultures and also did the JI panel, which detected Streptococcus pneumoniae. Now, this is a very unusual pathogen in a patient who is presenting with a community-acquired osteomyelitis, and whereas there is no respiratory symptoms without sinusitis, pneumonia, primary de novo strep pneumoniae, osteomyelitis is extremely rare. However, since this was the only etiology which was detected, we've thought of treating this. And the patient, with of course the GI panel which was there, we reached out to the second orthopedic surgeon and requested for the debridement. But at this point, both the orthopedician as well as the patient relatives as well, they were very apprehensive for a surgery and said that okay, we'll go ahead only with the antibiotics, see how it responds. So the patient was continued on ceftriaxone and linezolid. Now on this ceftriaxone and linezolid, the initial CRP definitely came down, but there was an increase in the fever, and with this, the other etiologies, whether it's drug fever, influenza, or some other etiology like TB, was also sought for. Since the fever was persistent, here the blood cultures were sent, and we must always send at least 2 or 3 sets so that we increase the sensitivity of isolating the bacteria. The antibiotics were changed to meropenem and teicoplanin, and we have this blood culture which is positive with the gram negative bacilli. Now, what do we do? As the patient was having severe pain as well as fever, the repeat MRI was performed, which showed that unfortunately the intensity and the infection had increased, the collection was present, and it had also involved the distal part of the radius. What about the gram negative bacilli, which was isolated? So we did the MALDI-TOF, which detected that it was Burkholderia. So here it was version 2, so that could not differentiate between Cepacia or Pseudomyeli. And the Vitek report showed that it was diagnosed as Pseudomonas aeruginosa. But as the colonies involved, and since there was a very close collaboration with the microbiologist, We said they identified it as Burkholderia pseudomoli based on the appearance of the colonies, as well as the biochemical test, arginine positive, lysine negative, and also sensitivity to the amoxicillin clavulanic acid. So, this was a case of Burkholderia pseudomoli resulting in community acquired osteomyelitis. This is very different and it's very important to diagnose it because the management is completely different from the Pseudomonas aeruginosa. So, how did he get this? He is an immunocompetent individual. And normally, Burkholderia pseudomyeli, we will expect in a patient who's diabetic, alcohol history, or has exposure to paddy fields. But sometimes this is also known as a Vietnamese time bomb. In fact, it has been isolated in American soldiers who have returned from Vietnam 62 years later. So, we investigated further and it revealed that there was some construction which is going in front of his house, a flyover drainage construction, which resulted in contamination of his potable drinking water. And though he was a surgeon and they had chlorinated it, but it was subchlorinated and it was using the water for gargling and perhaps ingested the bacteria. Now, with this comes the surgical plan. What do we do? So, we reached out to Dr. Agashi sir, who's an expert in bone and joint infections, and so was kind enough to tell us few tips that we should be making elliptical window rather than rectangular, small scopes to connect the cloacae, as well as he advised for the CT scan. And we did the CT scan prior to the surgery, which changed the way we would manage this patient. There was an impending fracture which was noticed at the proximal radius. And based on this, a more extensive debridement was sought out for with excision of the head of the radius as well as creation of that distal window. So this was conveyed to the surgeon and the debridement was performed now. And as soon as the elbow was opened, there was a pool of pus which just gushed out. The intraoperative specimen which was sent also grew Burkholderia pseudomyeli, and of course the expert MTB was negative. But during the perioperative period, he was on PCM, so fever was not there. Um, Later on, when he presented back home, the fever and the pain persisted. The antibiotics were modified, pimeropenem, minocycline, and later, because of the fever, it was switched to ceftazidime and minocycline. TMPS mix was not added because of the past history of allergy. But what do we do with this pain and persistent fever despite the debridement? So we prayed and reached out to the god of infectious diseases, our mentor, Dr. Rajiv Soman sir, who also emphasized that it is not the antibiotics. The antibiotics are proper, but it is the source control which is extremely important. So re-exploration was decided, which was also communicated, and sir was also suggesting that. So kindly with this, we reached out to the fourth orthopedician and who is Dr. Kandav Vidyarthi. He operated with tips for surgery through the telephonic consultation. And idea was to also do a distal opening first and then in the same sitting perform the proximal opening. So as we scrape or give wash proximally, the infected material can come out. So as soon as the intraoperatively, when the elbow was reopened, there was pus which was noticed at the surgical site. The intramedullary nailing was also performed, and antibiotic stimulant, as we can see here, was placed with ceftazidime antibiotic. Now, the story or the challenges continue with the treatment because Burkholderia pseudomyeli requires a long duration of treatment of probably 6 months or even longer. So, in this patient, ceftazidime as well as TMP SMX was switched post surgery, but he developed severe drug related eosinophilia with systemic symptoms, as we can see here. So the antibiotics had to be stopped. And later, when the ceftazidime was restarted, he again developed drug allergy. TMP SMX, he could not tolerate it either. Meropenem, which was later again restarted because there was intolerance to the antibiotics, developed leukopenia just after a few weeks. And minocycline, he was extremely anorexic, was just eating half a chapati a day. So what do we do? How do we treat this difficult infection? And can there be other options to it? So we reached out to Dr. V. Balaji, who mentioned that there is a novel antibiotic, levonarifloxacin, which has shown activity against Burkholderia pseudomyeli. And in fact, the MICs are much lower as compared to the ciprofloxacin. And compared to doxy or TMP SMX, it is much more active. Do we have experience with this particular molecule? So, in this patient with late onset prosthetic joint infection with MRSA, which was diagnosed on the basis of this GI panel, we had used it earlier for 4.5 months because this drug has bone concentration which is almost 5 to 6 times more than the serum, has cidal activity, has antibiofilm activity, and the patient also tolerated it for almost 4.5 months here. And so the patient was initiated on IV levonarifloxacin followed by oral ala levonarifloxacin, and in the follow-up scan, the WBC which was done later in August, almost 6 months later, there was improvement with just a little highlighted, which was lighting up, and later on the bone scan revealed no infection in November, and the antibiotics were continued for almost 9 months. We were fortunate to invite and present this in Darwin, Australia, and the 10th Melioidosis Conference. To summarize, melioidosis is a disease of surprises and its challenges in clinical diagnosis, lab identification, as well as in the treatment. And this illness is life threatening, requires multidisciplinary collaboration, which is important for the patient survival. This is our initiative. And for more information, you can scan this code regarding Burkholderia pseudomyeli. Thank you so much.
Time for one question.
One question.
Yeah, one or two quick questions and quick answers. Any questions?
So, no, this was really an exceptional case, but I want to point out that although, every time we broach this, Dr. Agashe says it's an exotic infection. Burkholderia pseudomyeli, India is the world capital of this organism. And among, series from Mangalore and stuff where they see most of this because it's in the Konkan belt, mostly found in the soil. Orthopedic infections, bone and joint infections are very, very commonly seen due to pseudomyeli in India. So it's something that we should be aware of.
I'd just like to add, during my post-graduation years, I've seen multifocal, and they present
Yes.
multifocal. And as you said, the Konkan belt, there's also a belt in the Andhra Odisha area, which also has the same thing.
Also up north, Chhattisgarh and all.
So there are a couple of belts in India, and I remember seeing a multifocal,
Yeah, absolutely. It is
very fit individual.
It's
We
endemic.
had a tough time going through that. Thank you.
Just one more point regarding, because I had one incidence of treating a patient who was then diagnosed with, so the case of osteomyelitis, it turned out to be Burkholderia pseudomylia. So going by our traditional teaching, we do a culture and the histopathology as well. So the histopath report in Burkholderia, because they are known to produce granulomatous
Granuloma.
changes. So we are tempted, so we need to inform our pathologist because the caseation part is not there, but the granulomatous part is there in the biopsy, which can mislead, and you can get a positive report showing suggestive of etiology of Cox, and then there is the discrepancy which happened in our case. So just pointing out this one more point here.
Absolutely.
It's a disease of surprises, and most important, it's very, very likely to be missed and can be life threatening. So be very, very careful about this.
And be careful that orthopedic surgeons are armed with such knowledge now. So your ID physicians have a run for your money.
Thank you very much. Thank you.
Thank you so
Great,
much.
great.
Thank you.